Please start.
Okay, so
Yeah.
good evening, everyone. It's a great pleasure to welcome you all for the today's webinar, Oncology Cancer Treatment Updates 2024. And I would like to invite program convener Dr. L.M. Darlong, sir. He is a chief of thoracic oncosurgery and chest wall deformity clinic, Rajiv Gandhi Cancer Institute and Research Center, Delhi. So to give his introduction and context setting, so it's over to you, sir.
Yeah, good evening, everybody. The update on oncology cancer updates, it will be talking basically on lung cancer, and we have involved both medical and surgical side. So it's, I think, mainly focused on early lung cancer and in some case, the oligometastatic setting. So we have a wonderful speaker along with us, and so we'll basically seeing in management of lung cancer in this present era, wherein I think we're getting more and more better response. We've got better medical agents, and of course, the surgeons, we are still doing what we used to do a long time back, though in a more less invasive and more with less mortality also, and better post-op recovery and giving more life, improving the OS with our medical oncology colleagues. So I think we'll go straight to our talk. I would like the team members to invite the first session. I think there's been some change in the sequence. So, Geetika, can you please ask the
Okay,
speaker?
sir. So I would like to invite Dr. Venkata Pradeep Babu, sir. He's a chief executive officer, Shankar Cancer and Research Institute. And this session is sponsored by AstraZeneca. And this topic is exceptional response to Osimertinib, EGFRM, metastatic NSLCS. So it's over to you, sir.
Thank you, Deepika. Thank you for the introduction. Is my screen visible?
Yes, sir, it's visible now.
Yeah. So good evening, Darlang sir, dear colleagues, and all the audience. So today I am giving this topic of presenting an exceptional response to osimertinib, particularly with regards to brain metastasis. So one of the most important challenge whenever we are dealing with lung cancer is brain metastasis, and because it portends really poor prognosis. And let us see, go through a case report which has shown an exceptional response to a third generation TKI osimertinib. So this is about a gentleman, 64 years old, who has presented with coughing, progressive breathlessness, and severe backache. He could not walk without support in the last 10 days, and he presented to ER with a giddiness since a history of 5 to 6 days. There have been history of weight loss of 5 kg in last 1 month, and he personally was not a smoker. So keeping in view of this cough, breathlessness, and severe backache, he was evaluated further initially with X-ray and later on which showed the lesion and then CT and PET CT scan. So the PET CT scan showed right upper lobe hilar nodes of 4 into 3 centimeters, and there are multiple bony metastases, which is responsible for his backache. Later on in the evaluation process, biopsy and molecular analysis was done. So initial biopsy was done from the lung mass because if we do biopsy from the bone, it will be not suitable for molecular analysis. So it was done from the lung mass. The histopathology, it is adenocarcinoma, and immunohistochemistry, it is TTF1 positive and APSIN-A positive and negative for P40. And in view of adenocarcinoma, non-smoking histology, he was sent for molecular analysis, and EGFR exon 19 mutation tested positive. All other mutations were negative, and there are no co-mutations. PDL1 was tested by IC and it was negative. Because they are bone mets and extensive metastasis, the lesion is quite large. So it's and it is EGFR mutated. So it's mandatory that we do brain scan at the baseline to rule out brain metastasis. And preferably, MRI is preferred over CT scan. And in this gentleman, MRI was done, which revealed multiple ring enhancing lesions in the cerebellum and cerebral hemisphere with significant perilesional edema and vasogenic edema. You can see here almost more than the lesion, the vasogenic edema is quite conspicuous, and because of which he was symptomatic. So now we have the final diagnosis of stage 4 non-small cell adenocarcinoma with exon 19 deletion driver mutation with metastasis in the bone and brain. So how to manage this case? One of the factors, if we see here, the lesions are in the critical areas, particularly there are lesions in cerebellum as well, and there is a vasogenic edema as well. We do know that whenever there is infarctular lesion with a significant vasogenic edema, it will lead to a lot of symptoms, and it is considered as a critical area. And that is the reason why this gentleman is treated with local radiation therapy for metastasis initially, and EGFR TKIs to exon 19 del. This is the plan that was made in the tumor board. And before going to see how he was managed, let us see a cross-trial comparison of 3-generation TKIs in terms of PFS. And we do know that Geftinib, Erlotinib were tried in IPAS and optimal trial, Afatinib, Lexan7, Dacomatinib, and Archer, and Osimertinib in FLAVA in a metastatic setting. And when we see the median PFS is highest with Osimertinib, and mind you, with that is a cost comparison trials, but in FLAVA also, even when we compare with the first generation TKI, it's quite significant with a PFS of 18.9 months, which was the highest PFS in the history of the lung cancer in metastatic setting. So, degree of CNS penetration by Osimertinib, when we see in the mouse models, it was seen that Osimertinib, when per mg per kg, had the highest penetrations compared to any other first generation or even second generation TKIs. So how do we know what is the penetration of the Osimertinib in the brain? Apart from the clinical assessment and responses, so there is a method to know the distribution of Osimertinib in the brain. So Osimertinib is tagged with carbon-11 molecule, and it can be assessed by knowing the distribution in the PET-CT scans, which are specialized PET-CT scans. And we can see here there is a significant distribution of Osimertinib when it is tagged with this radioactive molecule, and we can be seen the activity is across all parts of the brain homogeneously, mostly. So regional distribution and binding of Osimertinib in PET parametric images shows the volume of distribution in the brain is quite significant. Within 6 hours, when we inject the Osimertinib to a model, within 6 hours it reaches the brain. So when we see the treatment algorithm of a EGFR mutated NSCLC and CNS metastasis, there are 2 settings here, scenarios. The first scenario is similar to case we are discussing. They are newly diagnosed EGFR positive NSCLC with brain metastasis. Here, the important point to take decision would be whether the patient is symptomatic or not, whether the lesion is in the critical area or not. So if he is not symptomatic, the way to go is also to use 3rd generation TKI due to its excellent activity in the brain upfront. And if at all, if the patient is symptomatic for the brain metastasis, because it might take some time for the effect to take on. So local therapies, SRS or surgery. If it is a isolated metastasis, surgery can be done and can be removed, so as vasogenic edema and corresponding symptoms will be relieved immediately. The second scenario is patient might be kept on a 1st or 2nd generation TKI, and the lesion is there now with the recurrence of the lesion in the brain. And again, the question will be whether the patient is symptomatic or not. If the patient is symptomatic, definitely local therapy should be done. And if this patient is not symptomatic, then we should test ideally for T790M mutation. So if T790M mutation, if there are systemic metastasis, the way to go is to do a rebiopsy from the progressive lesion. If rebiopsy is not possible, we can do a liquid biopsy and see for the T790M mutation. Whenever there is a T790M mutation, the way to go again is Osimertinib. And if it is negative, go for the local therapy followed by continuing that same TKI or chemotherapy. That's how we deal with the patients with EGFR mutation and CNS metastasis. So even in the phase 3 trial, the FLAVA, and if you see the outcomes when compared to the first generation TKI, the hazard ratio for the CNS metastasis is 0.47, which means 53% of patients are prevented from having progression in the brain, which is quite significant. More than half of the patients are being protected from the progression in the brain. So even in those with the known CNS metastasis, when we see hazard ratio is 0.46, which is again is quite gives a lot of confidence in using Osimertinib in patients, particularly when they are not asymptomatic but they have stable brain metastasis. We can go directly with Osimertinib so that at least we are sure that half of the patient will not progress when responding systemically. So when we see the outcomes of the various TKIs, first generation, second generation, second generation and third generation TKIs. So afatinib has the trials of Lachlan 3 and 6, Lachlan 7 has included baseline brain metastasis, of course, who are asymptomatic. And when we see by numerically, the response rates in the brain seems to be 70% compared to 20%, but we need to understand that the numbers are small and they are not statistically significant. P-value is 0.029. In the same way, Archer trial 1050, they cleverly excluded all the brain metastasis, which actually will not give any confidence to use this molecule, although they are retrospective case reports. So, in the most important landmark trial by which Decomatinib is approved, there are no brain metastasis in the study. But in Osimertinib, both asymptomatic CNS mets were included. And we can see here the PFS is 15.2 versus 9.6 months, nearly 6 months gain in CNS PFS by using Osimertinib. So coming back to our case, this patient for bone metastasis received palliative radiotherapy to spine and zoledronic acid. For brain metastasis, he was not willing for the radiation due to concerns after the counseling done by radiation oncology colleague, the possible side effects. So he denied to take brain RT and he wanted to consider it when there are symptoms, progressive symptoms, fatal if it is not responding. So he was started on first line TK of Osimertinib 80 mg per day. And when we see here the follow-up PET CT scan, there is a significant response in systemic disease with a decrease in the size from 41 mm to 6.6 mm and decrease in activity on PET CT as well. And Osimertinib particularly has a highest amount of CNS response rate as well as disease control rate, which we have seen previously also. And so it is reflecting in this case study that when we have done the follow-up MRI brain, there is a complete resolution of the brain lesions on MRI brain. And so there is no additional intervention. The palliative RT, which was initially planned, was not given. So when we see the literature, case reports on Osimertinib and brain metastasis, there are so many, which are actually displaying a similar extraordinary response rates, particularly even when they are in a critical area. So you can see here, a 53 years old patient relapsed on stage 3A. There are lesions in the inferior vermian metastasis with surrounding edema, which actually is a critical area. And so he has ataxia and was scheduled for craniotomy and tumor resection. However, he was not willing and he was started on Osimertinib and there was a complete remission of the multiple brain metastasis. As many as 20 lesions when they are EGFR mutated. So it is mandatory that we do the mutation test because it is still thought as an additional test in many of the cases. It should not be. So it is a mandatory test, particularly when there is an adenocarcinoma. In squamous cell also, in those who are not smoking, it should be tested. And whenever it is present, so it becomes a lifeline for the patient. So, and the study demonstrated efficacy of CNS metastasis. We can see here phase 2 open label 3-arm prospective study, where 20 versus 18 into 10 cases was studied for the Osimertinib and the median PFS was 11.8 months. It is a real world study with brain metastasis, which is quite significant. So further follow-up with the PET CT, the partial response got converted into complete response and the brain response is still maintained. So the key points and food for thought is it's a very common scenario in the tumor board discussion whether we need to go for radiation or to start with the TKI, particularly in EGFR mutated osimertinib. So if the patient has a good response and the patient is not willing, definitely, and patient is asymptomatic, so definitely osimertinib is the way to go. And whenever there is a complete resolution of brain metastasis, radiotherapy may not be needed. Of course, close follow-up is needed. There are several case reports showing complete response both in brain and systemic disease. The patient remained progression-free even after 19 months after initiating osimertinib. Is asymptomatic, fully active, and able to maintain his quality of life by his doing all his normal activities. So we might need to find a biomarker which will help us in identifying such a excellently responding patients. Is there any other co-mutation that helps, absence of co-mutation that helps in predicting the excellent response to osimertinib is the question that we need to take from this study. Thank you so much for the opportunity.
Yeah, Dr. Venkat, that was a very nice presentation on lung for brain mets. So basically, especially in the present scenario with the good systemic agents we have, we are now dealing lung cancer oligometastatic setting, especially in the brain and adrenal, as something which is where you go in for local resection, local therapy like surgery, especially for brain mets. And obviously, the more you test for mutation, the more you're likely to get. And I think with the coming of osimertinib, which is very much accessible in the brain. Previously, the brain mets, it used to be a domain both of the neurosurgeons and the radiation oncologists. And with the coming of osimertinib, now we are having more additional options of giving an option, like in asymptomatic case, to go upfront with osimertinib. So I think testing is the way to go. In all cases, mutation is a very necessary process. We need to do more and more testing.
Yes, sir.
Any other inputs you have?
Testing is still a challenge in the peripheral area, sir. But in all circumstances, we should definitely do the testing.
Yeah, and to go further ahead, I think the tissue, the first time we should always try and get a core biopsy, because once you have the core biopsy, you can send the tissue, outside the blocks. So I think that really is very, very much important, getting the tissue, adequate tissue in the beginning, because you cannot subject our patients to multiple biopsies. The first time should be the first and last biopsy, I think so.
Yes, sir.
So I think we'll go on to the next speaker. Geetika, you can invite the next speaker.
Okay, so for the next speaker, I would like to invite Dr. Amit Sharma, sir. He's a consultant medical oncology from NSCLC, Kolkata. So it's over to you, sir. Dr. Amit, sir.
Yes. Can you move the slides as I requested you? Yeah. So as very wonderfully Dr. Venkat has already explained about the role of osimertinib in metastatic diseases. So now I am going to explain the role of osimertinib in early stages and why actually it is needed, to be very honest. First of all, we know that globally the 5-year overall survival in patients in resectable non-small cell lung cancer is somewhere around 50%, 45 to 50%. And it is one of the most leading cause of cancer death among the patients around the world. Next slide. So as in metastatic condition, in non-metastatic resectable lung cancer, upfront I would like to do the EGFR mutation testing, which include all the EGFR variation, including exon 19 deletion and L58R mutation, which are the most common mutations, along with the PD-L1 status, because nowadays we have adjuvant immunotherapy available as well after resection. And we have to see both of these biomarkers. Next slide. So this is the current testing and treatment pattern which we are showing in this particular slide. So prevalence of EGFR mutation in patient with stage 1-3 non-squamous non-small cell lung cancer. There is a study which is presented in ASCO recently 2023. And they have shown that the EGFR mutation prevalence is as high as 51% with deletion 19, and which is the most common, followed by L858R, which is around 36% of the cases. Next slide. So almost more than 2/3 of these patients underwent only surgical resection, and that's the thing which we have to work out. And a patient with stage 2-3 non-small cell lung cancer, only 46% received adjuvant systemic therapy. So next slide. So after initial treatment, as we can see from the previous slide as well, we can see that the more than half the patients with resectable non-small cell lung cancer experience recurrence within 5 years, and almost 50 to 60%, which include both local and distal recurrence. Next slide. So considering more than 50 to 60% of the patients recur in the later stage, in the later part of their life, it is unmet need that we should give something adjuvant. And in that way, adjuvant chemotherapy has been seen somewhere around 5% disease-free survival benefit in five years. In one of the trials, that is Anita trial, which shows in comparison to observation, there is somewhere around 5% benefit in disease-free survival. Next slide. So these are some of the selected trials. I mean, they are for 5 trials which have shown 3 of them shows some DFS benefit, but none of them shows any overall survival benefit, and 1 trial shows neither OS benefit or DFS benefits. Next slide. So the meta-analysis of all these 5 trials, which include which use TKIs in first generation or second generation TKIs, the overall benefit we can see in the DFS with hazard ratio of 0.5, but none of them shows any survival benefit. That is important to know. Next slide. So till now, we have till that point of time, all the trials are not able to change the clinical practice because these trials have limited design and size. Second, none of the trial, as we highlighted, that shows OS benefit. Second thing is, it is very unclear that these adjuvant TKIs actually results in the cure of the disease, or they simply delays the recurrence by improving in the disease-free interval. And third, last thing is, there is no definite period of time is mentioned in these trials about the duration of treatment. Next slide. So now we can see with the latest Adjuvant trial, which use the 3rd generation TKI Osimertinib. The trial design was patients who are completely resected, stage 1B to 3A, non-small cell lung cancer with or without adjuvant chemotherapy. The key inclusion criteria was more than 18 years, performance status 0 or 1, confirmed non-squamous non-small cell lung cancer with either exon 19 deletion or L858R mutation. Brain imaging is to be done, and patient who are included both with adjuvant chemotherapy or without adjuvant chemotherapy, and they are further stratified in terms of stage, EGFR mutation, the type of EGFR mutation, whether it is exon 19 deletion or L858R, or in terms of race, Asian or non-Asian, to the two studied arms. One is Osimertinib 80 mg once daily, and another is placebo. And they are further in terms of results. They are planned treatment duration is 3 years, and treatment continued until the disease recurrence or treatment completion or some other discontinuation criteria. And patients are followed up until recurrence, week 12, week 24, and every 24 weeks thereafter, up to 5 years. Primary endpoint is disease-free survival, and key secondary endpoint was disease-free survival in overall population, and overall survival, safety, and health-related quality of life. Next slide. So Adjuvant trial shows significantly improved DFS, which was and look at these patients, the difference between the curves. And this is something really great. I can say that look at the hazard ratios 0.2 and 0.27, which is never heard of previously with any adjuvant TKI or even adjuvant chemotherapy. Next slide. As already Dr. Venkat has shown that osimertinib has great importance in terms of penetrance into the CNS. So that is the reason the similar finding has been seen in the early stages as well. It increases because it has greater penetration in blood-brain barrier. It also helps in also demonstrated CNS DFS benefits, and that in the left side of our slide we can see that there is a definite gap between the two curves in terms of CNS DFS. Next slide. In terms of adverse effect, whatever common adverse effect we have seen in other settings like metastatic settings in the FLORA trial, the similar sort of adverse effect we have seen in the ADAURA trial as well. So most of the times it's grade 3 adverse effects are very few. 23 patients in comparison to the 14 patients, that is 79% versus 48% of the patients. None of the patient underwent any serious adverse effect. Next slide. So to key takeaway points is in order to improve survival, as we have seen 50% of patients recurred later on after surgery. We need to put more effort to identify lung cancer patients early. Never miss an opportunity to test for actionable mutation. And third thing is, it's always better to undergo multidisciplinary team meeting before starting any particular treatment. Next slide. So it is important upfront to discuss the patient about the favorable treatment options and best possible survival outcomes. And also important to discuss about the affordability of these treatments. And ADAURA treatment data also give probability of patient to remain cancer-free along with survival benefit. And this is something which we can give to our patients the best possible care. Next slide. So that's from my side. Thank you so much, Astra, to invite me. Is there any question? Then I'm happy to take on.
Yeah, Dr. Meet, there was a very nice presentation on adjuvant therapies in EGFR mutant lung cancers. Yeah, I mean, now more and more in early lung cancer, it is no more a domain of surgeon. As you can see, I mean, the medical oncologists are speaking first. And as a surgeon, I'm to speak last on early lung cancer. Previously, it was basically the surgeons who were basically doing all the work. But now with the coming of better targeted agents, we can definitely see better collaboration between the medical oncologists and the surgeons, and obviously the OS is improved. We are seeing more and more patients survive cancer, and especially in the early setting. So this is a very good move, and I think with other markers like for ALK also, we'll be having data soon, just like we have in ADAURA. So I think next time we'll be not just talking about osimertinib, we'll be talking about alectinib and other stuff also in the near future. So the most important thing, again, obviously, is basically testing. We need to test more and more cases, especially CAs and those non-smokers. So we can maybe find some mutation in them.
Correct. I think it's important that in the first meeting with the patient, even if it is surgeon or medical oncologist, we upfront discuss with the patient about the logistics as well.
Yeah, I also feel that. The only thing is that for EGFR, you need to do, so sometimes we do a PCR test just to get a result faster. For
Right.
ALK, I think that is more easier. You can do an IHC, but since we don't have any, RCT which has come up in phase 3, which is, result yet. So we don't do that ALK part. But EGFR, definitely we are doing in a PCR basis for the early case. For metastatic setting, it's a bit different thing. So I think in this way, the patients are aware these are the possible treatments. And obviously the cost has come down, which is also a very good factor, I think, in osimertinib.
Correct.
So any other comments you have?
No, that's fine. That's so.
Okay. Yeah.
Okay,
So thank
so
you very
move
much.
ahead.
Yeah.
So next
Next.
speaker, I would like to invite Dr. Sayan Kunduso. He's a consultant medical oncology from Kolkata, and to give us talk about optimizing treatment in advanced EGFR and lung cancers. So it's over to you, sir.
Yeah, am I audible?
Yes, sir.
Okay, just I'm sharing my screen. Yeah, good evening, everybody. At first, thank you, AstraZeneca, for inviting me to participate in this beautiful oncology update of 2024. And the topic of my today's presentation is optimizing treatments in advanced EGFR mutated lung cancer, mostly in the metastatic setting. So, as we know that EGFR mutations are observed at around 40% of non-small cell lung cancers, especially the adenocarcinomas in Asian population and around 20% in the non-Asian populations respectively. And if we see the Indian data, which was published from AIMS, I think the incidence rate of EGFR mutations among Indian patients is approximately 20 to 23%. So what is a EGFR mutation? EGFR mutations are located in the tyrosine kinase domain, and it results in the kinase activity of the EGFR receptor. So once the kinase enzyme gets phosphorylated, it leads to continued cell proliferation. So if a patient of lung cancer has EGFR mutated disease, we need to block the EGFR mutation by some agents which are called as EGFR inhibitors. So if we see the pie chart, the most common EGFR mutations are deletions. We generally see 4 exons, that is the exon 18 to 21, 18, 19, 20, and 21, of which exon 20 is the most hazardous. It is resistant to almost all the tyrosine kinase inhibitors. We have now some drugs against the exon 20 also. That's a separate part of discussion. But if we see the most common EGFR mutations, those are the deletions in exon 19 and point mutation on exon 21 L858R gene. So these two EGFR mutations constitute around 80% of all the EGFR mutated adenocarcinoma of lung cancer patients. So these are the 3 generations of TKIs which are available till date. Those are the first, second, and third generation. During our initial practice days, we used to start the treatment with erlotinib or gefitinib, which were the first generation TKIs, because the others were not available. During our residency or post-residency, afatinib came into the market. So it was the second generation TKIs. Next came the dacomatinib and the osimertinib. Osimertinib is the third generation TKIs. The basic difference between the first generation and the second and third generation TKIs are the first generation TKIs, that is the erlotinib and the gefitinib, they have a reversible binding to the wild type and mutant EGFR subtypes, and they are inactive on the most common resistant mutant, that is the T790M. While if we see the second generation and third generation TKIs, they have an irreversible covalent binding to the EGFR gene, and the third generation TKIs have a special specificity for EGFR T790M mutant gene also. So once a patient, if we start a patient on a first generation or a second generation TKI, if the disease progresses, we need to see the T790M mutation status and start on the third generation or osimertinib. So this was the data till date. Generally, we started with the first or second generation and progressively progressed to third generation. But nowadays, the data is something different, which I am going to discuss in the subsequent slides. So based on this background, this is the FLORA trial, after which the osimertinib, that is the third generation TKI, came into the picture as a first-line standard of care in patients with EGFR mutated advanced or metastatic non-small cell lung cancer. So FLORA was a phase 3 randomized double-blind study. It was studied to assess the safety and efficacy of osimertinib versus the standard of care EGFR TKIs, generally the first generation TKIs, as the first line treatment in patients with locally advanced or metastatic EGFR mutated non-small cell lung cancer. So if we see the basic structural difference between the 3 generations of TKIs, as I have already told, the first generation TKI have a reversible binding to the EGFR receptor. The second and the third generations have a irreversible binding to the EGFR receptor. And if we see the ability to cross the blood-brain barrier, in which the third generation TKIs or osimertinib has a distinct edge over the other 2 TKIs in the areas where there are brain mets and the drug gets penetrated to the brain because it is able to cross the blood-brain barrier. So osimertinib is a third generation irreversible CNS active EGFR TKI, and it is developed to selectively target both EGFR sensitizing and EGFR resistant T790M mutated patients. So if we see the mechanism of action of osimertinib, it has got a irreversible inhibition of both exon 19 and L858R, that is exon 21. Apart from that, it has got the additional benefit of inhibition of T790M mutated patients. It has got a lower activity against the wild type EGFR patients, and it crosses the blood-brain barrier as has been seen in human and preclinical models. So coming to the FLORA study design, the inclusion criteria were obviously patients more than 18 years of age with a ECOG performance status of 0 to 1. The patients had exon 19 deletion or L858R mutation, and the patients did not receive any prior systemic anti-cancer therapy or EGFR TKI therapy. The patients with stable CNS metastasis were allowed to participate in the study, and they were randomized into 1:1 model through osimertinib to a dose of 80 milligram orally per day, versus the EGFR TKI of standard of care. Mostly the patients received the first generation TKIs, that is the gefitinib or the erlotinib. So the uniqueness of the study was the crossover was allowed. So once the patients on EGFR, gefitinib or erlotinib developed progression of disease and developed T790M mutation, they were allowed to cross over to the osimertinib arm. The primary endpoint of the study was progression-free survival based on the investigator assessment according to the RECIST criteria. The secondary endpoints were many. Overall survival was a part of the secondary endpoint, and apart from that, the objective response rate, the duration of response, the disease control rate, and the depth of response, and obviously the safety of the drug was a part of the study. So this was published in New England Journal NEJM in 2018, and one of the key investigators of the study, basically the PI of the study, was Dr. Suresh Ramalingam from US. So if we see the Kaplan-Meier curve, the osimertinib demonstrated a significantly improved progression-free survival, which was the primary endpoint. So as PFS is the direct measure of the benefit of the drug, and FLORA was powered for PFS. So the median PFS was 18.9 months versus 10.2 months. That is 18.9 months for osimertinib versus 10.2 months for the first generation TKIs, with a very, very significant p-value of 0.0001. So if we see, it was the median PFS difference was almost to the tune of around 8 to 9 months. If we concentrate on the forest plot, almost all subgroups of the patients, the disease was favored by osimertinib as a first-line TKI if the exon 19 or exon 21 was mutated. for the CNS metastasis patients, for ECOG performance 0 to 1, for both the 19 and 21 mutated patient, any sex, any race, if we see the disease favored, the response favored the osimertinib arm in all the subset of patients. Coming to the overall survival of the drug with osimertinib, if we see there was almost 7-month improvement in median overall survival, and median OS was more than 3 years. So osimertinib patients were more likely to be alive at 2 and 3 year landmarks, and this is the first trial in which a EGFR TKI has translated the PFS to a significant overall survival benefit. So if we see the osimertinib versus the comparator arm at 3 years, 28% of the patients who received osimertinib continued with the EGFR TKI, that is the osimertinib TKI, versus 9% of the patients, only 9% of the patients were continuing the gefitinib or the erlotinib or first generation TKIs. If we see the another secondary endpoint, that is the time to first subsequent treatment, there was a huge difference. Basically, osimertinib patients had a double time to first subsequent therapy or death. So it was 25 months for osimertinib versus around 13 months for comparator group or the first generation TKIs. So comparing the PFS and OS forest plot of the osimertinib versus the comparator arm in FLORA trial, almost all subsets of patients, as I already discussed in the PFS arm, all subsets of the patient had an improvement with osimertinib rather than the first generation TKIs. If we see the OS, only the exon 21 mutated patients, L858R patients, had a comparable OS data with osimertinib versus EGFR TKI. But apart from that, all subset of patients had a better OS with osimertinib. So osimertinib's PFS benefit was clearly maintained consistently across all the subgroups, and all OS subgroups showed a positive benefit in favor of osimertinib, although the magnitude of benefit varies. So based on this FLORA trial data, nowadays osimertinib is being used as the first line TKI in metastatic NSCLC who has the exon 19 or exon 21 deletion. So why do we think it is important that patients receive osimertinib in the first line? So apart from the FLORA trial, we should concentrate on the real world data also. So if we start a patient with a first generation TKI, we have our real world data that approximately 30% of all patients are eligible for osimertinib at some point of time. So if we start 10 patients, I can show you in the next slide, basically. If we start 10 EGFR mutated patients on first generation or second generation of TKIs, around 73 to 77% of EGFR mutated patients receive the second line therapy. And the rest of 20 to 25% of patients, they either die during the first line or receive only palliative care on progression. So out of 10, around 8 patients, they get to receive the second line of chemotherapy, TKI. After that, around 60 to 75% of the patients receive a valid T790M test result, because once T790M is not done upfront, most of the patients are not eligible for tissue biopsy at that point of time, or have insufficient tissue from biopsy or an invalid test result. So out of that, out of the 8 patients who continued for the second line, only 5 patients had a valid T790M test result. So the valid T790M test result may be positive or negative. So osimertinib is not effective for the negative group of patients. So only 50% of patients who have a T790M positive result get to get the osimertinib. So out of the 10 EGFR mutated patients at start, if we start with the first generation of TKI, only 3 patients are eligible for second line or third line osimertinib at the end. So this has also been validated from various clinical trials that only 60 to 80% of patients can receive an accurate T790M test result, as has been shown in various trials and if we see the crossover rates and subsequent second line therapies for the FLORA experimental arm, the patients who had started on osimertinib, around 22% of patients are still on treatment. 78% have discontinued treatment. Out of this 78%, around 31% received no subsequent therapy or could not receive a second line therapy. The rest 48% received a second line therapy, which may be out of that around 30% received EGFR TKI other than osimertinib, or the rest were converted to cytotoxic chemotherapy. So around 22% of the patients are still on osimertinib who started on first line osimertinib. Coming to the comparator arm, only 5% are still on treatment. The 95% have discontinued. Out of that, 30% patients have had no subsequent therapy. Either they have died or they are on palliative care. Rest 65% of the patients, out of that, around 47% receives osimertinib, and rest 27% receives EGFR TKI or the second generation TKIs, and 22% around the cytotoxic chemotherapy. So this has been shown in various trials over the period that approximately only 1/3 of the patients, if we start with 10 patients, ultimately only 3 patients do not receive a second line therapy in phase 3, all the phase 3 clinical trials. So this is one of the real world data from Germany, out of 140 patients, 130 were treated with first line EGFR TKIs, and 10 patients received first line chemotherapy. Out of them, 112 patients were candidates for second line therapy, but around 30% of the patient did not receive any second line therapy, and the reasons were the patient refusal, the poor performance status, and the first progression, which led them to receive the cytotoxic chemotherapy. So around 1/3 of the patients do not receive osimertinib at the end of the therapy if we start with other TKIs other than osimertinib. So based on these are all the real world data across multiple countries, which confirm that in clinical practice, only 1/3 or fewer patients receive second line osimertinib. So why to deny these people of the benefit of osimertinib? That's the basis of the FLORA trial, which the results of which are published in 2018, and it came that osimertinib can be used with a good PFS and OS benefit as a first line therapy. So concentrating on this slide, this is the treatment sequencing in advanced EGFR mutated non-small cell lung cancer. If we see if osimertinib is used as the first line, the PFS, as I have already shown in the FLORA trial, it is around 18.9 months or 19 months. After progression, patients receive chemotherapy. So the PFS goes up to 40 months in a patient of metastatic NSCLC if the patients are started on osimertinib. On the other hand, if the patients are started on any first generation TKIs, the median PFS is around to the tune of 10 months. Then if the patients are converted to osimertinib, another 10 months, and then to chemotherapy. So hardly around 32 months of PFS if the patients are started on first line EGFR TKI. So there is definitely an edge of osimertinib over other first line TKIs if it is started as a first line. So the key messages from this are that the osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. The FLORA trial was the first to demonstrate how an EGFR TKI has translated PFS into an OS benefit. Osimertinib improved OS versus first generation EGFR TKIs in untreated EGFR mutated non-small cell lung cancer and T790M mutated non-small cell lung cancer. Osimertinib has the edge over other TKIs, that is, it is the only EGFR to report statistically significant intracranial efficacy. It's very well tolerated drug at a dose of 80 mg per day. Adverse effects leading to dose reductions are frequent in the second generation EGFR TKIs, as we face day in and day out with dacomatinib, because the standard dose is 45 mg. We generally start with 45, and then we have to reduce to 30 mg within 2 or 3 months because of the side effects of diarrhea. And sequencing cannot be considered the best strategy, as almost 70% of patients are not eligible to receive osimertinib in the second line. So these data confirm osimertinib as the first line standard of care in metastatic EGFR mutated non-small cell lung cancer. If we see the NCCN guidelines also, if it is a EGFR mutated metastatic NSCLC, category 1 evidence is osimertinib nowadays. It has come in 2023 only, 2023-24. And so osimertinib should be used as a first-line TKI in metastatic non-small cell lung cancer. So with this, I finish my talk, and thank you. And thank you to AstraZeneca for inviting me.
Thank you very much, Dr. Kundu. It was a very nice presentation. Osimertinib going from DFS to OS.
Yeah.
So this reminded me about a phase 2 trial, the North Star trial. It's basically for metastatic setting, wherein, for EGFR mutant, they had got into the role of local consolidation therapy, either in the form of surgery for local site and radiation for metastatic site. So, the systemic agents, especially the targeted ones, have really opened the Pandora box in the metastatic setting, even for a local therapy. So this phase 2 trial, the North Star trial, wherein osimertinib was used for metastatic setting with those with EGFR mutant, I think will give us a future direction, regarding management of metastatic setting also with those with mutation.
Yeah, definitely. And even for early stage lung cancers, if you operate, if it's a EGFR mutated disease,
Yes,
exon
for early
19 or
stage, we
21,
are, that's,
we
now
are going to
that
follow up with
recommendation,
those.
but now, it's opening the door towards the metastatic setting also.
Yeah.
Yes. And that's a welcome sign both for the surgeons and for the radiation oncologists. We are having more opportunity to, increase the cure rates in lung cancer in the stage 4, which was unheard of in the previous.
Mostly it will become a chronic disease in the future.
Yes, it is becoming slowly and slowly. So thank you very much, Dr. Kundu.
Thank you, sir.
So thank you so much, Dr. Shyamson. So I would like to invite Dr. Adam Dalon, sir, and this session is sponsored by AstraZeneca, and to give us talk about managing early lung cancer surgeon perspective. So it's over to you, sir.
Okay, thank you all very much. And so in the early lung cancer, now the surgeon is coming last, though usually the sequence used to be that surgeons do the job mainly in the beginning. But now times are changing. We have more of medical colleagues also helping us in curing lung cancers. So I would like to touch upon the burden of lung cancer in India, standard of care, and regarding the type of surgeries for lung cancer, and obviously the NCC guidelines and the data we have presently. So this is the Globocan data on India. You can see it's the 4th overall most commonly in terms of incidence. It's being preceded by breast, oral cavity, oral cancers, uterine cervical cancers, and the lung cancer. In terms of the death also, it's the 4th common cause of death in the Indian setting. And these are the classification. The majority of it is basically non-small cell, and small cell comprise about 12.5%, and other rare types are about 3.2%. And these are all, I think we all know it. This is again a beautiful slide which shows that the size of the tumor, basically when you catch it, is very, very much important, because you can see here in 1A1, that's basically 0 to 1 centimeter in size. The 5-year OS is 92%. And when you catch it at 1 to 2 centimeter in size, OS is 83%. This is with surgery. And when it up to 3 centimeter, just 2 to 3 centimeter, it's about 77%. And that gradually reduces to about 53 and to about 36% by the time we come to stage 3A. That's basically nodal involvement. So the scope of surgery is mainly till about stage 3A, that is N2 disease, which we'll be talking about here. So if you see the stage-wise prevalence, in India, you can see the stage 1 is just a minuscule 1.2%, and stage 2 is 3.8%, and the bulk of it is stage 4, which is about 67%. And next comes the stage 3 disease, which is basically a borderline between operable and inoperable. That's really something which requires MDT. And if you see in terms of the gender-wise distribution in India, in males and females, it's almost similar. Surprisingly, I mean, we are seeing more of localized only in females. Though, I mean, usually what we see on ground is that in females, they tend to present every day more late stage because we don't suspect them to have lung cancers. We have a notion that lung cancer is mainly a smoker's disease. So they tend to usually present late because of the neglect and because of the bias that we have with smokers. So looking at the standard of care, it's first we need to diagnose it, do a clinical staging, then MDT, see about resectability and resectability, and based on that, you either go for a upstage new adjuvant or you go for a surgery, and then it all depends basically on the staging of the disease. So as we've said, I mean, more than 75% of cases are diagnosed in the late stage. That's how it usually is. Stage 1, stage 2 are usually, I mean, the cases which are to be going for surgical resection or local therapy whenever the patient is fit for surgery. And stage 3 is one area wherein we have to do an MDT, a must, and a thoracic surgeon needs to be involved because we need to see whether the disease is resectable or unresectable. And for N2 and N3, these are, there's not much debate. For N3, it's basically CTRT is the standard of care. For N2 disease, I mean, we have to decide upfront whether how the patient goes. Is surgery part of the multimodality management or not? Because if not, you need to basically go the CTRT way and the immunotherapy way, as we have the Pacific trial presently. And we can see that only 25% of patients are eligible for surgery in lung cancers, and the rest, about 75%, are mainly unresectable. So this is the percentage-wise distribution. You can see stage 1 and stage 2, about 33.5%, stage 3A, 13.1%, stage 3B, 30.1%, and the bulk of it in stage 4 disease. Again, looking at the treatment based on molecular alteration, resectable is again 25%, unresectable again 25%, and metastatic 50%. Unresectable, again, you have to see most of these are basically, I mean, stage 3 disease. And then it's very important again that the surgeon is involved to see whether it is resectable or not from the beginning, because we cannot say, okay, we're going to give some systemic therapy, reassess. I mean, that's not how it should be done. I mean, we have to make it upfront that whether the patient will have a local therapy in the form of surgery or not, because if not, if it is a doubtful case, in that case, it's best to undergo a CTRT and follow the Pacific route using immunotherapy. So these are, again, basically surgery is a mainstay in all these cases in early stage lung cancers. Again, we talked about this. Again, the resectability is the main assessment needs to be done by a team, a thoracic surgeon or an oncosurgeon who does specifically in thoracic. He has to consider things like the feasibility in terms of the size, position of the how resectability is, whether the tumor is again multi-station or not. The question about multi-station is again very, very doubtful because we now have the phase 2 Nadim study going on. We're looking specifically into multi-station N2 disease, wherein they have found a very good PCR. And so this will still be a area of debate, especially for multi-station N2 disease. But with the advent of immunotherapy, I mean, we need to consider them in the MDT, whether they need to undergo surgery or they should be going straight for CTRT. So this is again the stage for 1 and 2. We've all talked about it. Every centimeter counts, 1 centimeter, 2 centimeter, 3 centimeter. That's how it is in the stage 1. And for stage 2, it's basically 3 to 4 and 4 to 5. So every centimeter of the tumor size definitely matters in lung cancer because that changes the whole management. This is just to give you an idea about the staging, stage 1, 2, 3A, and 3B. So we all know basically about this. And stage 3B, and sometimes we'll have it basically because of tumor size, though it is N0, N2. But the primary site is basically resectable. It is not invading the mediastinum. In such case, they are locally resectable, but they are basically N2. But because of the size or because of the involvement of adjacent structures, they become stage 3B. So these needs to be considered along with your surgeon in terms of surgical resectability. So these are some areas, wherein a discussion with the surgeon is very important in the MDT setting. So everything, needs to be discussed upfront. What is the intent of treatment? How do you sequence the treatment? Again, this comes in the management of such case regarding resectable lung cancer. So, one thing is whether the surgeon has to decide whether the lung is resectable or not, the tumor is resectable or not. And MDT is definitely very important that decides on the eligibility for surgery. And because sometimes the surgeon is the main point of contact for the patient. And surgery should be done with the intention of doing a complete dissection, that is basically R0, and an adequate lymph node resection, and an adequate sampling or dissection to be done during the surgery as per the ISLC criteria, because lymph node staging is very, very important in lung cancer for adequate staging and further management. So even in resectability also, there are surgeon factor and there's medical factor. Like patient is unlikely to tolerate surgery because of the morbidity and possible mortality of surgery. So this needs to be decided both by the MDT and the pre-operative evaluation that we have in terms of pulmonary assessment, cardiac assessment, and other risk factor based on the age. And the most important is that most of them are chronic smokers, so they be medically inoperative because of poor pulmonary function or other comorbidities. So this needs to be taken into account when you are looking at resectability. So these are the various, again, stages: stage 1, stage 2, stage 3, and stage 4. So in all these things, the role of surgery is there basically for stage 1, stage 2, and for stage 3. And we have various modalities of doing the surgery in terms of accessing it in terms of thoracotomy, VATS, robotic. All these modalities are there. But what is important is that the aim of the surgery should be to have a complete resection, R0 resection with complete nodal clearance. Coming to stage 3A, it is a complex and varies depending on extent of tumor invasion and lymph node involvement. So MDT is definitely very, very crucial for stage 3A disease because we need to decide upfront, because they need perioperative systemic therapy, especially with the coming of immunotherapy. These are, more and more considered for perioperative immunotherapy, followed by surgery. So these are basically the other factors that when a patient is to be undergoing surgery, what factors need to be taken into account, like the anesthesia risk in terms of pneumonia that you have possibility, and other factors like bleeding, infective, and what is the recovery period. All these are things which are discussed in the perioperative period. But now with the advent of minimal invasive surgery, we are now able to discharge our patient even by the 3rd or 4th day and with minimal morbidity. And most of them are not getting their systemic adjuvant treatment if necessary, or not delayed because of post-operative morbidities. So most of them are able to undergo the systemic agent treatment at the correct time because of lesser invasive modalities that we have now. So looking at the types of surgery that we are doing, we can have a lobectomy, pneumonectomy, a segmental dissection, but still now the standard of care is basically lobectomy. Pneumonectomy is something which we try and avoid, because when you do a pneumonectomy, it's like giving a person a disease, because pneumonectomy in the long run is more like a disease. This is especially true for those on the right side we try and avoid pneumonectomy. And in those we do pneumonectomy, those are very select case. And that will be more on the left side, or in those cases who are very young and who have got a very good chance of survival. And after a lot of discussion with both the patients and our medical oncology and radiation colleagues, that we may decide to do a lobectomy, especially for the right side. Left side can be considered more unlike the right side. So these are the, we all know about open thoracotomy, then VATS, and of course the other things like robotic, all these things. So in open thoracotomy, this was the traditional way, but we have slowly moved away from this. We're using more of VATS, wherein the surgery is less morbid, the patients recover more early, and the chances of wound infection are less because the wounds are small, and then they're able to take the systemic therapy at a faster rate, and there is less chance of blood transfusion when you do a minimally invasive surgery. And that also reduces the chance of immunosuppression, which is known to affect in terms of blood transfusion. And of course, we have the robotic system now, wherein for very early cases, we are able to do it with more ease. The advantage of this is that in robotic, you are able to have better lymph node yields, though it has not been proven, and in a randomized trial, it improves OS, but definitely it does help increase the nodal clearance, and it can be done with ease in the early cases and with a very good perioperative recovery. So coming to again the resection for lung cancer, it's very important that lymph node dissection is done, and systemic lymph node sampling is operated during pulmonary resection. So all the nodes should be sampled at from the mediastinum, at least 3 stations. That is on the right side. If you're doing level 2R, 4R, it should be taken en bloc along with 10R, and then level 7. And whatever nodes you're seeing, and then interlobar, that's basically level LN, and 12, you can sample it once the specimen out. And then sometimes we do see level 8 and level 9. So all the nodes which are seen on table after dissection should be basically in the dissection on the sample box and should be sent to the pathologist, because this gives us an adequate staging of the primary side, because tumor side, we know, I mean, is going to come out, but lymph node staging is definitely very, very important in terms of final pathological staging and patient receiving adjuvant treatment. So these are the basic NCCN guidelines, which you all know about it, and this is basically evaluating perioperatively for all such cases. A PFT, a bronchoscopy, a mediastinal node staging, a PET scan is something, and then obviously MRI brain with contrast is to be done in all cases. Some cases, some patients, some centers don't advocate, and though NCCN says for stage 2 and stage 3, and stage 1B is optional. But we know that for adeno-CS, I mean, with those with a high SUV uptake, there's very high chance of missing brain mets on a PET scan. So in our center, we always do MRI brain with a contrast in even early cases, because there's a chance of missing it in about 8% of the cases on a PET CT, especially for adeno-CA with very high SUV uptake. So these are basically the findings that you have post-surgery on the specimen, and the aim should be basically R0 resection in all cases. You can see here R0 is in those with whom adjuvant is required. It's basically either chemotherapy or do for EGF mutation testing. In that case, you have Osimertinib as one of the agent with those with exon 19 deletion or L858R mutation. And obviously now there's again role for immunotherapy, even the adjuvant setting with atezolizumab or a pembrolizumab, which can be added in those which are mutant, EGFR mutant negative. So this is basically the perioperative systemic therapy. I mean, now all patients are being evaluated for a perioperative chemo IO in those indicated, especially for those with tumors more than 4 centimeters in size, and there is no contamination immune checkpoint inhibitors. That's basically the mutation is negative. And adjuvant setting, we all have this osimertinib now presently, and obviously there's atezolizumab and the pembrolizumab from recent trials. This is the Checkmate 816. I would not be going into details about it. This is basically one of the first phase 3 trial which came out regarding the role of neoadjuvant nivolumab, which is purely, I mean, in the pre-op period only, which was showing better pathology complete response as a surrogate for improved OS. Other ones that like the IMpower 010 and Keynotes 091 are basically in the adjuvant setting. And this is what we have, the phase 3 trial, ADAURA, which is, we've already heard about it. The trial has matured and it has shown an OS benefit in all cases of this, with overall survival of 88% in the Osimertinib arm compared to around 77% in the placebo arm at 5 years. So this is now one of the standard of care in early lung cancers with EGFR mutant cases. And these are just one of the, I think we've already spoken about this. And so it's important that in early lung cancers, wherever we have got actionable mutation, it is necessary that we give the benefits of actionable mutations. So in these non-metastatic, non-resectable lung cancer, EGFR and testing is definitely very, very important, because those with mutation positive are able to benefit from the trial that we have, that is the ADAURA trial. And also the PDL1 have also gives us an idea about those with mutation negative regarding adjuvant IO. So thank you all very much. And so this brings us to the end of our talk. So I would like to conclude by saying that, I mean, now lung cancer, I mean, the whole spectrum, basically from early lung cancer to metastatic setting, has become more of a multidisciplinary setting. Like I've said in the beginning, the tumor size, which are about 1 to 3 centimeters, these are the only case scenario in which surgery is the sole therapy in those which are medically fit. If not, they can go for SBRT, those which are inoperable, medically not resectable. Otherwise, for any tumor more than 3 centimeter and with mutation coming in, there's a whole gambit of now giving EGF systemic therapy in the form of Osimertinib or other TKIs. And obviously, we have also talked about the metastatic setting also. In that case, there are now trials going on. Like we have the Lone Star, that's for immunotherapy. We have got a North Star, basically using Osimertinib. And the Bright Star, it's basically again for Brigatinib for ALK positive cases, wherein we have role of local consolidation therapy for such metastatic setting in the special setting. So I think the role of surgery or local consolidation therapy is going to increase beyond the realms of stage 1 to stage 3A to more of stage 4 setting. Also, we do have now roles in the oligometastatic setting regarding role of surgery. So I think in the future, we are going to see more and more case scenarios wherein we'll be having more role of surgery in the metastatic setting only, combined with our radiation oncologists who are giving precision or targeted, very focused radiation. So thank you all very much. If there's any question, I think we can take question and then we can wind off.
Is there any question and comments? No, sir. So thank you so much, Darlong, sir, and
yeah.
all the faculties and delegates to join this webinar. So can we close the meeting now, sir?
Yes. Thank you all. Thank you all very much, all the faculties and all the participants. Thank